since the start of this pandemic that they're at the highest risk of complication and death, and if they contract this coronavirus. So obviously, these patients are really afraid. And so there's this erroneous perception that there's no resources or staff to provide urgent or emergency care for non-COVID patients. And so many of the hospitals have done these outreach efforts through social media, public health messages to say, listen, we're here, we're open for you even if you're a non-COVID patient, as long as you have a cardiac issue, we're here to help. And really the ACC has been front and center in this also. The ACC developed an infographic called Coronavirus in Your Heart. This went on CardioSmart. This is an educational portal for the patients. And it said, don't ignore heart symptoms. And it details common MI and stroke symptoms. And it encouraged patients who think they're having an event not to delay calling 911 because of fears of contracting COVID-19. And it really, what we're trying to say is, look, the hospitals are ready to take care of you, that they have the protective gear and protect you so that you don't have to worry. And really the emphasis for this is to say the safety is important. And I think the key is to get that message out to the patients that we're here. And so, yes, we need to have a vigilance about viral transmission, but we don't need to distract from an equally important message to our patients, which is COVID or no COVID, we're still here to take care of you. And so the key message to the patients are, patients with symptoms need to overcome their fears, get prompt treatment so that we can save their lives. Because we're really concerned about the downstream effect, right? Are we going to see an uptick in the heart failure and the late presentations? I mean, at least anecdotally, and I'd love to hear Gregg's comments, at least the cardiologists from New York that were on for our COVID webinar, the last one, they were saying that they're seeing late presentation MI. And I can tell you that 2 weeks ago, I had a patient, 43 years old, that had been having chest pain for 2 weeks and ended up going to the urgent care after 10 days, came to see me, called the following day, called me and saw me, and he was in the midst of an acute anterior MI. I took him to the cath lab and his LAD was occluded. We opened that up. He had a very large diagonal. His ejection fraction was 35%. Now, obviously, I expect that to improve. But we are hearing these types of reports throughout. And so I wonder, Gregg, if the reason that you're saying that those numbers, COVID numbers, are getting that is because some of those are not really COVID patients, but some of the non-COVID patients that are being included. So I'd love to hear a comment on that. But I think the ACC's point is to support the cardiovascular professional with education and a resource. So I really encourage everybody to go to acc.org and also to be a resource for the patients so that they actually get attended to, because our cardiac patients, it's important that they don't ignore something because of the fear of COVID. So I'm going to stop there because I know we're running over, and I'd love to have Gregg's comment on my comment. But thank you very much, Dr. Gupta, and to the rest of the panelists.
Well, thank you. I think your comments were excellent. First of all, ACC is doing a tremendous job in getting this information out and coming up with very rapid, societal-based guidelines and recommendations on how to deal with the pandemic that are just being widely appreciated. So thank you for that. Yes, this phenomenon about the percentage of patients presenting with STEMIs in our hospitals is absolutely real. Everybody's reporting it. I think that 40% reduction that Tim Henry reported is probably accurate, and it seems to be increasing the decrement over time. So we'll see where it settles out. The question is what's causing it. I think a lot of it is that patients are staying at home with symptoms, especially more mild symptoms of heart attacks. And it's interesting because we are giving them mixed messages. In one sense, we're telling them, look, if you have mild flu-like symptoms, don't come to the hospital. That's the worst place for you. Stay at home. On the other hand, sometimes flu-like symptoms and heart attack symptoms can overlap. And now we're telling them, but of course, if you're having heart attack symptoms, come to the hospital, we'll take care of you. So I think a fair amount of it is that patients don't want to come to the hospital in this current setting. And so they're trying to manage at home, again, especially with less severe symptoms. And you're right, we're definitely seeing patients now with mechanical complications of MI that we haven't seen in years because patients are coming in late. There's obviously, statistically, there's competing risks of COVID. Some patients are presenting with both COVID and myocardial infarction. And again, with these troponin elevations that are being treated conservatively, may not be being counted. So there's probably a whole different set of reasons why this is happening. Some people have said, well, it's because people aren't being active anymore. so they're not having exertional triggered infarcts. I don't know if that's true, but it's probably multifactorial. But the bottom line is, I think that certainly after ARDS, which is the number one cause of death in COVID patients, cardiovascular complications is number two. And we again, with these troponin elevations, especially rapid elevation of troponins, are markedly, strongly associated with impending death. So we have to make sure it's not due to underlying coronary disease in a situation that's treatable. And we do have to reinsure our patients about what the symptoms of heart disease are like within the midst of this COVID pandemic. And if they do feel that they may have either a heart attack or impending heart attack, that they still should, call their provider and come to the emergency room when appropriate.
Well, and I think early on, Greg, people were waiting for the COVID test to come back. If they presented they had elevated troponins before they decided to take them to the cath lab. Right. I think people were being very conservative, and I think that now people are doing what you said, which is you wear the PPEs, you take the appropriate precautions. But if you believe that the patient needs to get to the cath lab, they're going. I think there's a little bit of a shift there, because initially we said just do thrombolytics, be more conservative. And then we started to get more experience, and I think we're a little less hesitant now as long as we're protecting ourselves appropriately.
No, I agree. And again, I think going back to thrombolytics would be the wrong thing to do, especially as there's a high, thrombolytics only work in half the patients, and there's a higher incidence of normal coronaries, again, in STEMI in this setting. So giving lytics to these patients would not be appropriate. And half of them are going to have to come anyway within 24 hours for either acute rescue PCI or for recurrent ischemia. So we shouldn't go back to a thrombolytic area if we can still reperfuse patients with primary PCI within 2 hours. Mm-hmm. And that said, I will tell you, there's a lot of board interventional cardiologists right now. In the United States, we've pretty much, in most municipalities, shut down elective procedures. We're starting to slowly open up in some regions for the really, sick, higher risk patients, with suggestions of multi-vessel disease or very symptomatic patients with aortic stenosis. But for the most part, all we've been doing is PCI in STEMI and acute coronary syndrome recently. I look forward to being able to slowly open that up again, but I think it's going to be with full PPE for a long time.
Right. I think the most interesting question is that there are other theories about why those numbers have gone down. But there's some of the behavioral modification. In other words, eating at home, maybe some decrease in stress because people are working from home, not running around, the air pollution, all of those other theories that are out there, and wonder if some of those behavioral modification took away some of the triggers also. And I think those are going to be answers that are going to be difficult to tease out. And I think we're going to be having discussions about this for a very long time.
Agreed.
Yeah, there are actually, thank you very much, Dr. Dipti, a very nice presentation on ACC, and I would like to have one or two comments from other people before Dr. Gregg will be allowed to leave. Dr. Abdul Rashid Khan is from Pakistan, and Dr. Mansoor Ahmed. Dr. Mansoor Ahmed missed to speak last time. Dr. Mansoor, are you here? Dr. Mansoor Ahmed?
Before Mansoor comes, Vivek, can I pose a question to Dr. Gregg Stone?
Yes, why not? Yes. Dr. Mohanan is a president-elect. He's a president-elect from CSI.
Mysteries about the death rates, which is absolutely true. Possibly one way to understand the death rate is to track down how many days it took for the total deaths to double. See, we in India, again, has a very low death rate. The only comparison that I could say with the New York and India is the doubling time for the death rate in New York was almost just 2 to 3 days, while in India it's about 9 days.
Right. And I think that is a good way to look at it. But again, it all depends on what you attribute to be a death due to COVID versus a death due to something. And that's what's so difficult. Absent in-depth serologic or autopsies, and a lot of the causes of death are multifactorial. So I think that.
Sorry, there is some problem. I will mute all.
Dr. Gregg. ऊपर नीचे करो
Okay, Dr. Stone, can you answer this question? Sorry, there was some problem technical again.
Okay, can you hear me now?
Yeah, I can hear you, but I'm trying to put your photo here. I'm not able to see it.
Okay.
But you are very all loud and good. You are listening to. We are listening to you.
No, I was just saying that yes, looking at the time to doubling of the number of deaths is a good metric to look at. But the key thing is really how we're attributing deaths, whether deaths are being appropriately attributed to COVID versus other causes, and that's what's so difficult. And a lot of the deaths at home are not being counted as COVID-related deaths. Deaths are multifactorial. It's hard to know, other than if somebody clearly dies in just frank ARDS, whether or not it's a COVID-related death. So, there have been all sorts of thoughts that I think in the United States and in China and elsewhere, the number of COVID-related deaths are markedly being underestimated. And I think that's really true. Again, epidemiologically, if you look at the number of people who have died, for example, in New York City over the last 3 years, say during March, okay, it's been actually very constant for the last 3 or 4 years in March. You get X number of patients, and now we're seeing overall 2X number of patients that have died at the same period. That gives you, given that there's nothing else major that's been going on, it gives you a sense of the overall burden of COVID mortality has been to about double mortality. And that takes into account some of the good things COVID's doing, decreasing motor vehicle accidents, homicides, et cetera. So I do think we're markedly undercounting mortalities. And in India, of course, with such a large, huge, bustling population, again, I would have a very healthy skepticism in terms of the number of cases and number of deaths, frankly, in every country, but certainly in India as well.
Dr. Mohanan is a president-elect of Cardiological Society of India. He's an important person. He's a very nice gentleman. Let me request Dr. P.C. Rath, if any comment, or Dr. P.K. Ashokan to come in. They are our panelists. Before you leave, actually they have one question. Dr. P.K. Ashokan? Yes, Ashokan, I can see you. You have to unmute yourself.
Can you hear me?
Yes, Dr. P.C. Rath, please come in. Yes, Dr. P.C. Rath, please. We can hear you.
In the cath lab, are they doing this COVID test before taking the patient? For any patient coming to emergency, before taking the patient to the cath lab, are they doing COVID test for all the patients?
Well, I can just answer from my perspective, but I think it depends on the urgency of the situation. If you think it's urgent, if it's a primary PCI, then no, we're not. We may be drawing the test. We're not waiting for it to come back. We just do it and assume the patient is COVID positive and take the patient, and treat him or her with personal protective equipment. Obviously, in patients who have non-ST segment elevation ACS and they may be able to go in a day or two, then you have time to do testing. But again, there's a significant number of false negative tests, especially early on. So even then, I would be very concerned and err on the side of using personal protective.
What we are doing, we have limitation in doing the test. So what we are doing, all the patients, we are doing a HRCT and then taking consult with the infectious disease consultant, then taking the patient. But we are not doing this test because we have limitations in the test. It takes 24 hours for the result to come. That is why we are not doing that, depending on the HRCT.
So maybe Dipti can comment on that. I mean, a lot of people are using, because of the lack of availability of PCR or ELISA testing, a lot of people are using chest CTs. But I don't know the sensitivity and specificity of chest CTs, especially in minimally or asymptomatic patients who may be carriers and therefore may have a normal chest CT. So,
of course, we are taking the PPE, but that is what we are doing. Thank you very much.
So we've done some chest CTs, but I can tell you I agree with Gregg that I don't think that the sensitivity specificity is there. We've actually had several patients that had some symptoms. They got sent for chest CT. They thought they saw something that was COVID-like changes, and then it turned out that their COVID test was negative. And so I think that you end up going, I think these are still early. It's early on to learn what the best methodology is, but we're not doing testing on everybody. I think I agree with you, Greg. We're being selective, you know, and I agree that there's early on there's a lot more false positives. So you just have to sort of go clinically and use that guidance. And like I said earlier, I think now with us being more protective of ourselves as well as the patient, we're not quite as hell bent on knowing that result before we proceed. If we fix it's clinically indicated.
Okay, so let Dr. Mansoor Ahmed from Pakistan come in. We missed him last time. So Dr. Mansoor, would you like to have some comments? He's an interventional cardiologist in Karachi. He's our friend for a long time and a very nice gentleman. We are not able to hear you. Something wrong in your system. Maybe we'll take you later because you are unmuted from our side, but we cannot hear you. We are seeing you very well. You can ask question on the chat. Dr. P.K. Ashokan, would you like to say something?
That's a very informative discussion. So my question is, the fatality rate in USA is not very high and almost equal to India. The fatality rate, mortality rate. And the outcome depends upon two factors. That's what I understood from your talk. One is the age, other one is the cardiovascular comorbidities. So my question is pertaining to taking the patient for reperfusion strategy. Which case you take, whether they extend the COVID or because of the cardiovascular involvement. Some patient may be having very late presentation, like say ARDS and renal failure or sepsis. So which case, but is there any selection criteria for subjecting the patient for intervention?
So I think it's a great question, and I think you have to individualize every case, like we always do. So if you have a patient with a classic nuanced head pressure chest pain and ST segment elevation, if you can, slap a very quick transthoracic echo, see if there's a regional wall motion abnormality, and if so, in general, as long as that patient is reasonably stable, you would probably want to take them to the cath lab. You have to realize that a lot of the troponin positive patients in COVID-19 are not due to a type 1 myocardial infarction with the typical plaque rupture and thrombosis. So you have to, there's going to be a higher incidence of normal coronary arteries or non-obstructive coronary disease, and you can make patients worse. By exposing contrast, I think you have to individualize every case. Try to take the patients who you think are going to benefit from the cath lab, and that's going to be those patients who have obstructive coronary artery disease.
Okay, so I think Dr. Abdul Rashid Khan from Pakistan would like to say something. Dr. Abdul Rashid Khan, my friend for a long time.
Thank you very much, Vivek Gupta, again for asking me and involving me in this COVID presentation. It was really nice presentation from you and all the others. My question is still with hydroxychloroquine. What should be the limit of QT interval in QT when we can give as a safely as a prevention, not as a treatment? Can I be the answer?
But I'd love to hear actually from the ACC what their current stance is right now on hydroxychloroquine.
Well, I think it's what you said earlier, Greg. I don't think there's data that supports long-term use of it, particularly for the COVID patients. And then there's actually an article on COVID Hub that talks about the arrhythmias with the different as well as the hydrochloroquine combination. But right now, it's hard to say. I think we need to wait for the clinical trials to see what's actually working. So it depends. I didn't hear the question fully.